Okay, so welcome back after lunch, and we would be a bit slow because post lunch you must be feeling a bit drowsy, and we would be having the most difficult topic coming up after this, that is the squint and neuro-ophthalmology. So I would be a bit slow. We would study about the retinoblastoma, the eyelid disorders, the eyelid tumors, and then we would take a small break, and then we go for the last topic, that is the squint and neuro-ophthalmology. Okay, so retinoblastoma is the most common intraocular tumor of the children. Remember, it is the intraocular tumor of the children, that is the retinoblastoma. If we talk about the most common intraocular tumor of the adults, then the answer is different. In the adults, it is metastasis from the other organs. If we say primary intraocular tumor of adults, please note, then it is uveal melanoma. Okay, so am I audible, everyone? Okay, so this retinoblastoma most commonly seen in 2 to 5 years of age, and the gene involved is RB1, which is a tumor suppressor gene. So we have different type of mutations that can be there in the tumor suppressor gene RB1, which is responsible for the retinoblastoma. Now this retinoblastoma can be both unilateral or bilateral. Bilateral retinoblastoma is all the bilateral retinoblastoma is heritable. Okay, so gene can go from the parents to the child, but that does not mean that unilateral are not heritable. In unilateral, 85% are non-heritable and 15% are heritable. Now, why I am telling you this theoretical part? The question they would ask is that in which of the patients the genetic counseling is important for the parents. So they would give option of unilateral retinoblastoma, they would give the option of bilateral retinoblastoma, optic nerve glioma, and melanoma. So out of them, both unilateral as well as bilateral retinoblastoma, in both of them it is important to do the genetical counseling, because bilateral is 100% heritable, but even unilateral can be heritable. Now the question comes is, what is the most common presentation of the retinoblastoma? So we talk about how the retinoblastoma comes. The patient comes with the white pupillary reflex. So they would give you a question. A 2-year-old child came to the OPD with white pupillary reflex. What is your first diagnosis? So most common is leukocoria. Okay. Then the second most common is strabismus, squint. Okay. So this is the most common presentation. Then sometimes they would ask that this is the child which is having a white pupillary reflex. What is the another cancer that can be seen in the patient? Are you getting my question? They would ask that a patient with white pupillary reflex has come with the intraocular mass. So you know the patient is having a retinoblastoma. What is the secondary cancer that can be seen? So the most common secondary cancer in these individuals is osteosarcoma. Okay, there is another term which is sometimes asked, that is a trilateral retinoblastoma. In trilateral retinoblastoma, we have a bilateral retinoblastoma plus pinealoblastoma. Then we have a quadrilateral retinoblastoma, where we have bilateral retinoblastoma plus spineloblastoma plus any supracellular tumor. One more question they ask from the retinoblastoma is most common site of metastasis. Can anyone answer? Most common site of metastasis of retinoblastoma. Now you know retinoblastoma is in the intraocular region. So what is the nerve which is basically going from the eyeball to the brain? It is the optic nerve. So it is a clean path through which the retinoblastoma seeds can basically go into the brain. The most common site of metastasis is your CNS, and most common pathway of spread of the retinoblastoma is optic nerve. Okay, now we come to the how can basically we diagnose a retinoblastoma. So what are the investigations which we have to do when we see a patient of retinoblastoma? The most important investigation is first to dilate the patient and see if you can see the intraocular mass. So we do an examination under anesthesia. We see the anterior segment. We see the retina posterior segment. With the help of a indirect ophthalmoscope, I would show you how the indirect ophthalmoscope looks like. To see whole of the retina, we see the eye pressures, and if we see if there is any other pathology in the eye, we see the corneal diameters. So whenever the basic funda is that the question asked was that when a child of 1 year comes to your OPD, let's say they ask a child of 1 year comes to your OPD, you cannot see the fundus in the OPD and the patient is having squint, what is the best investigation that you would do? So some students said, sir, I would do a retinoscopy. But remember, retinoscopy would not detect a retinoblastoma. And I told you that the second most common presentation of retinoblastoma is squint. Are you getting my point? So any patient of squint, you have to do a complete retinal evaluation to rule out a retinoblastoma. Are you getting my point, everyone? Okay. Then for diagnosis of intraocular mass, we have a technique which is called ultrasound. So ultrasound B scan, B bole to brightness, is done to see if we can see a intraocular mass in the eye. I would just show you how it looks like. Can you see here? Now this which you are seeing, this is a large intraocular mass. You can see some spikes also corresponding to this. This is ultrasound B scan showing a retinoblastoma. Now why this is important? Because you have to pick this, because if you basically treat it easily, treat it early, you may save the life of the patient. So the next thing is that after basically detecting the with the ultrasound, you are able to detect the retinoblastoma. What is the second thing you do? You have to basically see whether this retinoblastoma has gone to the other parts of the brain or not, and if it has involved the optic nerve as well. So the second investigation you do in these patients is MRI with contrast, gadolinium contrast we give to see its extension to various parts of the CNS. Whenever you have a retinoblastoma, bilateral retinoblastoma, you do not do one investigation, which is CT scan. So CT scan is not done. The reason is it can basically expose the patient to secondary cancers. Remember, the bilateral retinoblastomas are very, very notorious to have the secondary carcinoma. Now, because we have come from lunch, so there may be a slight amount of drowsiness in you. So one question to make your gray matter work. My question is that what is the most common secondary cancer in the patients of retinoblastoma? Tell me in the comment section. I have just told you. Okay, so very good. This is the most common secondary cancer is osteosarcoma. Okay, so now we come to the staging of and grouping of retinoblastoma. You do not have to go into the details. What are the first, second, third, fourth retinoblastoma? Basically, you have to just remember that as the size increases of the retinoblastoma, it basically have a more advanced stage. So there is group A, which is a small tumor. As it grows, comes near to the more important structures of the eye, that is your optic nerve end and macula, it becomes B. It basically does a seeding. There are more retinoblastoma seeds here and there, becomes C. Goes to group D, where it basically goes to the CNS, and if it extends to the other orbital area and other places in the body, it is E. So group A is less severe and group E is most severe. Now why this is important? Because group A you can basically treat with conservative measures like laser, thermotherapy with the infrared rays, or cryotherapy. And for group B, C and D, you have to use chemotherapy. And in E, you have no option. You have to remove the eyeball. That is called enucleation. Is it clear, everyone? So we have group A, B, C, D, E. If anyone of you wants details of what is the grouping, I don't think it is needed. But if anyone wants, you can get it from me after the class. Okay, we would send you the PDF. It is there in the notes as well. So B, C, D, we basically use chemotherapy. Now there was one question which was asked regarding the chemotherapy in retinoblastoma. The chemotherapy has a regimen which is called VEC regimen. So V goes for vincristine, E goes with the etoposide, and C goes with the carboplatin. So we have VEC regimen whenever we talk about the chemotherapy. Okay. Now, what happens is that sometimes the questions are asked a bit differently. So the question is that the retinoblastoma is a tumor which is having a calcification. So they ask, can you tell me any other lesion in the eye which also have calcification? So other things which can have calcification are, I told you, one lesion in the cornea. Can anyone tell me which has calcification? It is there in the Bowman's membrane. Calcification is there. We call it band-shaped keratopathy. Okay. Then we can have optic nerve head druseness. Okay. Or osteomas. Now these are the various conditions which can have the calcification. So these are some important points regarding the retinoblastoma. Now we come to, if there is a patient with orbital tumor, what are the things which we can do in the patient? Now I told you, whenever the patient is having Let's just show you a picture. Okay, I told you in group E retinoblastoma. So what is the treatment option? You have to remove the whole eyeball. Now, if I remove the whole eyeball, this is called enucleation. Okay, so when we do enucleation? When we have a intraocular tumor. Let's say we have a intraocular tumor. So indication of enucleation is any intraocular tumor. Can you name any other intraocular tumor besides retinoblastoma? So I told you it can be a uveal melanoma. Now, very important is if the patient is having a panophthalmitis. What is the meaning of panophthalmitis? The whole of the eye is having inflammation. Okay, you are having inflammation of sclera, you are having inflammation of uvea, you are having inflammation of choroid. So in that case, because we have to remove whole of this area, okay, and if this area is inflamed, okay, the chances are the inflammation can go to the optic nerve, okay, or any infection can go into the optic nerve and into the brain. Are you getting my point, everyone? So any cases of panophthalmitis, the enucleation should not be done. Are you getting my point? Give me a thumbs up. So why? Because if you, whenever you have to remove the optic nerve, you have to remove the whole eyeball. You would cut a part of optic nerve, and when you cut a part of optic nerve, the infection of the globe can go from the optic nerve into the brain. Now, it is very much psychologically bad for a patient to get a enucleation, that whole eye is removed. Sometimes, even when the eye is not seeing, patient says that, sir, please maintain the shape of my eyeball so that the person who is in front of me can basically see that there is an eyeball, even if it is not working. So this is basically called evisceration. So what we do in the evisceration is, we cut the cornea and part of sclera, and after that we go inside with the scoop. Scoop is like an ice cream scoop. Are you getting my point, everyone? So we go inside with the scoop and remove whole of the intraocular content. Okay, so with the scoop I basically remove all the content. So after removing all the content, I put a implant. Inside, and then I suture the sclera. Okay, then you can put a cosmetic contact lens over this. This process is called evisceration. Are you getting my point, everyone? So the cases like anterior staphyloma, where the cornea itself is already damaged, or if we have other conditions like the patient is having mutilating injury to the eyeball, perforating injury to the eyeball, in that condition too, we can basically do the evisceration. Now, one thing that I just forgot to tell you, that let's say if the patient is having a perforating trauma to the ciliary body. Now, perforating trauma to the ciliary body can basically cause damage to the other eye as well. I told you yesterday, what is that condition called? When one eye is basically involved and the other eye also can be involved later. So this is called sympathetic ophthalmitis. Okay, so this is called a sympathetic ophthalmitis, where one eye is involved and other eye can also be involved. Very good, Dr. Mohan. So in that cases also, before there is a reaction of one eye into the other eye, we remove the whole eyeball. So another indication of doing enucleation is to prevent sympathetic ophthalmitis. You get my point? So that there is no hypersensitivity of the antigen that goes from the one eye to the other eye, because sympathetic ophthalmitis can develop even after weeks of trauma. You have got injury, maybe today, maybe 2 months or 2 weeks out of the 2 weeks after that, you get a sympathetic ophthalmitis in the other eye, because remember, this is a hypersensitivity reaction. Now, before I close the orbit, now this is a bad situation. Let's say we have a lacrimal gland tumor, or let's say we have a retinoblastoma which has extended even to the orbit, or we have a sebaceous cell carcinoma which has involved the orbit as well as your eye. Now in these conditions, you not only have to remove the tumor from its space, you have to basically take the periosteum as well. So exentration, you remove the eyeball, you remove the part of eyelid, as well as you remove the periorbital fascia as well. So in an exentration, you remove the eyeball plus orbital bone plus extraocular muscles plus lids. Okay, so extensive surgery is basically needed in these cases where your not aim is to not only just sacrifice the eyeball, your aim is also to basically protect the other parts of body from the metastasis. Now, whenever you are doing an enucleation, whenever you are doing an evisceration, one thing you have to basically rule out is the patient should not be having any intraocular tumor. Why? Because if there is an intraocular tumor, if there is a retinoblastoma and you are doing a evisceration surgery, when you are with your scoop inside the eye, you can basically touch the blood vessels and blood vessels may be open. So with that blood vessels or capillaries or lymphatics, the seeding of the intraocular tumor can be there in the other parts of the body. So intraocular tumor can spread through that open vessels to the other part of the body. So they ask that what is the contraindication of doing a evisceration. So contraindication of doing a evisceration is any type of intraocular tumor. Give me a thumbs up if you are able to understand this. A very, very important point. Okay, now we move to the next orbital disorder, which is called blowout fracture. Now, what happens in a blowout fracture? Maybe due to a blunt trauma, a significant blunt trauma, your bones, your maxillary bone, that may be fractured. So inferior rim of your orbit may be fractured, and through that fracture, the content of the orbit can go into the maxillary sinus. Okay, so this is my maxillary sinus. So the content of orbit goes into the maxillary sinus, and this is basically called a, have you ever heard the name? Teardrop sign. Okay, so teardrop sign is basically, if you can see here, this is the content of the orbit in the maxillary sinus, and this is basically there in the blowout fracture. Is it clear, everyone? Should I move to the eyelid part? Okay, now we move to the next section of, or the next chapter of the oculoplasty, that is the eyelids. Okay, we would be talking about this portion of the eyeball. This portion of the eyeball, this is my eyelid. Okay, now whenever we talk about the eyelid, a very important thing is that what is the function of the eyelid? It is basically placed in front of my eyeball. Okay, so this is my eye, okay, and this is my eyeball. So it is basically covering my eyeball, and its main function is to protect the eyeball. So this is a muscle, this is a part which is basically working all the time, day in and day night. So unless otherwise you basically sleep, these muscles, they are always working. Okay, so it is basically acting as a shutter to protect the eyelids. Is it clear, Dr. Digvijay? So that is the basic aim of your eyeball. Now if you can see in this picture, your upper eyelid, okay, your upper eyelid is basically covering 2 millimeter of your cornea, and lower eyelid is basically touching the cornea. If you can see, the upper eyelid is basically covering 2 millimeter, and the lower eyelid is touching the cornea. Now this is very important, because whenever we talk about the disorders of the eyelid, that is that if the eyelid is basically drooping down, we call it as a ptosis, then there would be more than 2 millimeter of eyelid that would be covering your superior cornea. Or if this portion, basically lower eyelid, it basically goes down, then what happens is that this may cause a sclera inferiorly to be seen. Okay, so this is called the superior and the inferior eyelid. Now if you can see here, this portion which I have basically put an arrow, this is the eyelid crease. You can see a eyelid crease inferiorly. Similarly, you can see a crease superiorly. Why this is important? Because we would discuss that behind the crease there are many muscles, many attachments which are useful in doing the surgery. So similarly, I told you we have the canthus, we have the outer canthus, we have the inner canthus. Okay, so this is my inner canthus, this is my outer canthus, and the space between this canthus, okay, the space between the two canthus is called horizontal palpebral aperture, and the space between the up and down, that is called a vertical palpebral aperture. So this is my vertical palpebral aperture, and this is my horizontal palpebral aperture. Okay, horizontal is around 28 to 30 millimeter, and vertical is around 10 to 11 millimeter. Okay, this is the basic funda of your palpebral aperture. Okay, now we come to the structures of the eyelid. Okay, so when we basically see the inferior eyelid, it is made up of many structures. So you can see the eyelashes. Okay, then beneath the eyelashes we have various layers of the eyelid. I would go one by one. So the one which you can see here, the red one that I have done, this is my skin. Okay, so beneath the skin we have a muscle which is basically responsible for contraction of your your eyelids. So opening and closing the eyelids, that is by this muscle. This is called orbicularis muscle. So we have a orbicularis oculi, which is basically responsible for that. Behind the orbicularis oculi, we have the tarsal plate, which is the connective tissue, which makes the skeleton of the eyelid. And in the tarsal plate, you can see there are some glands which are called meibomian glands. And superiorly, where it touches the eyeball, we have a line which is called a gray line. Anterior to the gray line, we have the eyelashes, and posterior to the gray line, we have the opening of meibomian ducts. Now, though it looks quite boring, what is the clinical significance? So clinical significance means that eyelid is not a simple structure, it has multiple structure. Even if you are not able to remember all of this because you have 19 subjects, so just remember 3 points: that there is a muscle which basically closes the eye, there is a connective tissue which makes the eyelid firm, and there are few glands in the posterior part of the eyelid which basically lubricates your eye. And here you tell me, I have told you when I talked about the tear film that meibomian gland secrete which layer of the tear film? So my question is very good. So meibomian gland basically secrete the lipid part of your tear film. Now this one was our lower lid. Similarly, we have a upper lid, and we have almost same structure in the upper lid as well. Just remember, the upper lid has a muscle which basically opens the eye, and this muscle is called levator palpebrae superioris. Have you ever heard the name? Give me a thumbs up. We have a levator palpebrae superioris in the upper lid, which basically opens the eyelid, and we have two accessory glands here, which are the glands of Wolfram and Zeiss. Remember, the meibomian glands do not open in the eyelashes, but the Zeiss glands basically open in the eyelashes. What is the importance of these glands? I would tell you in my further lecture. Okay, so that is the basic funda of your glands. Now, I told you meibomian glands, they are so important when we talk about the lipid film of the tear. Now, whenever you have a meibomian gland dysfunction, we told you the patient would have a dry eye. Now, which type of dry eye it would be? Would it be a evaporative dry eye or a aqueous deficiency dry eye? So lipid abnormality would be there. This would be causing a evaporative dry eye. Okay, so if you can see, this is a real-time picture of one of my patient. If you can see, these are my eyelashes. Okay, and these are my inflammation and pus that is extruding from the meibomian glands. Can you see this? Now, why this is important, this picture is important, because if they show you this picture and ask if this patient is having a dry eye, what is the type of dry eye in this patient, you would see that eyelashes are anteriorly and the glands are posteriorly, and these glands are basically causing the sebum or the pus material to go out. So this is meibomian gland dysfunction. Remember, always meibomian glands are posterior to your eyelashes. If the disease is on the eyelashes, if there is a gland swelling on the eyelashes, which glands it would be? It would be Zeiss glands. Okay, we would discuss about the Zeiss glands also, but before we go to the Zeiss glands, we go to a congenital abnormality of the eye. Now let's say if there is a patient where the whole of the iris is not formed. Okay, so if the iris is not formed inferionasally, okay, what is this called? Anytime where there is a defect in the formation, this is called coloboma. And this is called a iris coloboma. Similarly, if the eyelid is not formed, a part of eyelid is not formed, we call it eyelid coloboma. If a part of retina is not formed, we call it fundus coloboma. If a part of optic nerve head is not formed, we call it optic nerve head coloboma. Okay, so the problem is that whenever there is a coloboma, there is a defect. You do not have to basically confuse this with a festooned pupil. Why I have shown this picture to you? Because in festooned pupil, you would be also having a abnormality of the pupil, but there it would be a full pupil that you can see, though the shape of the pupil would be more irregular. Here, inferiorly, you cannot see the iris, as well as there is a long oblong pupil in this case. So do not confuse a iris coloboma with a festooned pupil. Is it clear, everyone? Okay. Now we move to the inflammatory disorders of the eyeball. So when we talk about the inflammatory disorders of the eyeball, the first thing comes to our mind is, so many times you must have seen in your internship a condition like this in your maybe friends, in your cousins, or in the OPD. Your eyelid is swollen. When the eyelid is swollen and there is an acute inflammation, there is an acute inflammation of the eyelid, this is called stye. Okay, so stye is basically also called external hordeolum. Okay, and the glands that are involved are the glands which are there on the eyelashes. Tell me, which glands are in the eyelashes? I told you when talked about the anatomy. So the stye is external hordeolum, which is because of the glands of Zeiss. Similar type of lesion can be there when in your palpebral conjunctiva. What is your palpebral conjunctiva? This is your palpebral conjunctiva, which is basically having the posterior, lining the posterior surface of your eyelid. So when the posterior surface of the eyelid has infection, nodular infection, that is basically called internal hordeolum. And remember, internal hordeolum is basically because of the infection of meibomian glands. So here comes another mnemonic. The easiest injection to give is intramuscular. So IM is easy. Okay, so internal hordeolum have the meibomian gland disorder and external hordeolum have Zeiss gland infection. Do you all get my point? So those friends who want to see all the mnemonics and how we can basically use the mnemonics in solving the MCQs, you can basically get the mnemonics in ophthalmology video from me, where I have basically put all the mnemonics in one, which you can basically use whenever you are studying ophthalmology. Okay, the next thing is the chalazion. Now internal hordeolum is there. We have basically done a bit of treatment, but it was not resolved. Now it has gone into a chronic inflammation. Now the chronic inflammation is there, which has basically formed this type of picture. Now there is a nodule in the upper lid, and this nodule is basically not a painful nodule, but it causes a foreign body sensation, and this basically is cosmetically also not okay. So this is basically chronic non-inflammatory, chronic non-infective lipogranulomatous inflammation. Are you getting my point? So Ajit, please remember the words chronic non-infective lipogranulomatous inflammation. So this is basically due to the meibomian gland infection only, but now it has gone into chronic form and now it has become a nodule. Now very important is that if you do a surgery of this chalazion, remove it, but it comes again and it is coming again and again, if there is a recurrent chalazion, this is a risk factor of a type of eyelid tumor which is called sebaceous cell carcinoma. Okay, so very important is, this was a last year question, that recurrent chalazion can have a sebaceous carcinoma, sebaceous cell carcinoma. So how to treat it? We can put a intralesional triamcinolone, that is the steroid, or we can do it a incision and curettage from the conjunctival side with avoiding the horizontal incisions. Now my question is, why to avoid the horizontal incisions in these type of patients? Now see, whenever we put an incision on the skin, there can be a scar there. Okay, so scarring over the eyelid may be cosmetically not very good for the patient. Patient says, cancer, we avoid the scar. So what I do in these cases is, now this is my eyelid, I evert the eyelid. Okay, so we evert the eyelid, and after everting the eyelid, let's say there is a chalazion. Okay, we basically put vertical incisions here. Now you would ask me, sir, why vertical incision? Because I told you that there are meibomian gland ducts in the eyelid. If you can see, these are the meibomian gland ducts. Give me a thumbs up. So these are some vertical ducts that are there. If I put an incision, here, this would basically cut the meibomian gland duct, and this would lead to the dry eye, the lipid-based dry eye in these patients. Okay, Dr. Swaroop. So that's why, even that was a boring discussion regarding the anatomy of the eyelid, it has practical considerations, because whenever we do a chalazion surgery, we have to avoid to cut the meibomian gland ducts. So I make this incision vertical to avoid damage to the meibomian ducts. Give me a thumbs up if you are able to understand this point. Okay, chalo. Now what are the other disorders which we should be basically remembering when we talk about the eyelid? So the ones which are commonly asked is trichiasis. Trichiasis is basically a disorder where the eyelashes, usually they do not touch the eyeball, but if these eyelashes, they are turned inwards and they touch the eyeball, they can cause a damage to the epithelium. All of you get my point? So that is inward misalignment or turning of eyelashes is called trichiasis. Now there can be lot of causes of trichiasis like trachoma. Okay, there can be burns, chemical injuries. Okay, so all these can basically cause or even entropions. I would tell you what is entropion, but all of them can basically cause a trichiasis. Now second thing which is sometimes asked is distichiasis. Now this was a all India question. Distichiasis. Normally when we talk about the eyelashes, there is only 1 or 2 rows of eyelashes. Now if these eyelashes, there are more than 2 or 3 rows of eyelashes, if there are extra row of eyelashes, then this is called a distichiasis. It can be congenital or it can be due to any inflammatory response like burns or a syndrome which you must have heard the name, that is the Stephen-Johnson syndrome. Now before I move to the eyelid cancers, we have 2 more type of eyelash disorders. In one, there is a loss of eyelashes. So madarosis is eyelashes are lost. It may be psychological or sometimes it is a side effect of cryotherapy, radiation, or even sometimes infection. The infection of the anterior part of the eyelid is called blepharitis. So that can cause madarosis. So eyelashes are lost there. And if we get graying of eyelashes, it is called poliosis. So poliosis is graying of eyelashes. Okay. So with this, we basically come to the end of various eyelash disorder. Now there are 2 more eyelids disorders which I want to discuss. The first one is the inward turning of the eyelid margin. So if we have inward turning of the eyelid margin, this is called a entropion. Okay, if you can see here, give me a thumbs up if you are able to see. So there is a eyelid margins which usually are opposed, but here they have inward turned, and this basically causes the eyelashes to touch the cornea. This is called a entropion. Okay, the second one is ectropion. Now in ectropion, what happens is that there is a outward turning of the margins. Okay, so the lid margin which is going inward in entropion is now going outward. Okay, so you have more cicatrization, more inflammation, more watering there when we have ectropion. Okay, so these are the 2 important eyelid disorders of the inward and outward misdirection. Now sometimes what happens is the patient has got a 7th nerve palsy. Now in 7th nerve palsy, the patient is now not able to have a control over its orbicularis and he cannot basically close the eyeballs. So inability to close the eyeball. This is called a lag of ophthalmos. Have you ever heard the name? So this is called a lag of ophthalmos. Now very important is that in these conditions, because there is a lag of ophthalmos, the patient is not able to close the eyes. The eyelid would be exposed to the eyeball would be exposed to the outer environment, and there would be a dry eye, and slowly the cornea would also be damaged, and this condition is called exposure keratopathy. Do you all understand? So because the eyeball is not able to close, there would be a evaporative dry eye, which would ultimately lead to the exposure keratopathy. So what we can do in these cases is we can do a procedure which is called a tarsorrhaphy. So I basically put a, if you can see here, okay, so we have put 2 sutures there and close the eyelid. This can be a permanent or this can be a temporary. So let's say this is my eyeball. It is not closing. So now what I have done is I have put two sutures here. I have put two sutures here and artificially closed that. Okay. NS wash. Sorry, Swaroop, I cannot basically get your point. So we basically put the sutures around the eyelid. So this is basically called a tarsorrhaphy. Okay. So this is how I have basically put the sutures around and close the eyelid. This is called tarsorrhaphy. So they would ask, how they would ask a question? They would ask a question like that. A patient with a paralytic stroke has been admitted in the ICU, and after being admitted in the ICU, the doctor has examined that there is a exposure keratopathy. Which surgical procedure would you basically do in this patient to basically cause a which can basically be used to close the eyelid? Then answer would be the tarsorrhaphy. Okay. Now there is one more important point that I want to basically discuss before going for the ptosis. That is that there is an involuntary rapid frequent closure of eye. Now look it like this. Whenever we study, whenever we do something, we basically open the eyes, we close the eyes. We open the eyes, we close the eyes. But if we are doing like this, so first of all, this would be cosmetically bad. And second thing is that we would get a lot of strain there. After some times, we would basically feel a lot of pain and heaviness in the eyeball. And this rapid blinking, forceful closure of the eyeball, this is called a word which is called a blepharospasm. Okay, so this is called a blepharospasm, which is basically the involuntary rapid opening and closure of the eye. Now what happens here is, to avoid that, first of all, we want to counsel the patient. Sometimes these are functional causes. And second thing what we can do is, we can avoid the hypersensitivity of the nerves. So we can put some injections to basically reduce that over the eyelids. Can anyone tell me what are the injections that are used to basically avoid this hypersensitivity of the nerves based on one bacteria? So this is Botox injections, which can be given as a treatment in these patients. Is it clear? Okay. Chalo, let's move to the ptosis. Now ptosis is a very important thing, very important topic of the eyelid, and most of the questions of the eyelid are basically asked from ptosis. So what is ptosis? Ptosis is basically defined as a condition where there is a drooping of eyelid. Now, any drooping of eyelid, would it be called as a ptosis? The answer is no. Normally what happens is, I told you when I started the eyelid section that around 2 millimeter of eyelid is basically covered with the 2 millimeter of cornea is basically covered with the eyelid. If more than 2 millimeter of the superior conjunct cornea is covered with the eyelid, then it is called a ptosis. Now this ptosis can be a congenital ptosis or it can be an acquired ptosis. Now this is a child with a congenital ptosis. You would ask me, sir, why? Why this patient is a congenital ptosis? Now see the eye. Okay, so can you see the lid crease in this patient? Yes or no? Now let's say this is my left eye. Now I would show you, those students who have just joined late, I would just show you how the lid crease looks like. This is the lid crease. This is a superior one. This is the inferior one. And this is our child. So can you see the lid crease in this patient? The answer is no. We cannot see the lid crease in this patient. This is because when the lid crease is not seen, when the lid crease is absent, okay, so this is basically the patient is having a congenital ptosis. What are the other things which basically tell that there is a congenital ptosis? There would be history that after birth the patient is having this condition, and when he looks down the eye does not follow it. Now what I mean here, this is called lid lag on down gaze. Do you understand till now what is the crease? What is the meaning of lid crease? Everyone give me a thumbs up, because now the point is more, you need to apply more mind to understand this. What is the meaning of lid lag on down gaze? Now see here, I am seeing you, this is my primary gaze, okay, and when I see down, okay, I am seeing down. So when I am seeing down, my lid also goes down. Please appreciate that, and if you can appreciate that, just give the thumbs up in the comment section. So when I look down, my lid also looks down. Okay. So what happens in these patients is that when the patients of congenital ptosis are there, that when they look down, their lid is not following their eyeball. So this is called lid lag. So the upper lid does not follow downward movement when the eye goes down. Okay, now this is called a lid lag on down gaze. Remember, whenever the patient would have acquired ptosis, the lid crease would be present. The patient would not be having since birth. So the patient would say that maybe 30 years or 40 years down the lane, he is getting that, and there would be no lid lag. So that is how we basically can differentiate between the acquired ptosis and the ptosis of a congenital origin. Now my one question to you is that there is a patient who comes to the OPD. He says that I am having ptosis. There is a drooping of eyelid. The patient is a 26-year-old male, and the patient says that, sir, in the morning I am okay. In the morning I am okay, but when I come back in the evening, I feel my lids are going down. There is a ptosis, and when I put a cold pack over my eyes, then my eyes open fully. Now tell me, what is the reason here? So putting a cold pack or using a hydrophonium test in these patients would basically cause the eyelid to open fully. So what is your diagnosis in this case? Is it a HIV? It is a hepatitis B, multiple sclerosis, or myasthenia gravis? Tell me the answer. So very good. These patients would be having a myasthenia gravis. So the most important cause of the acquired ptosis, where it opens with hydrophonium test or after being given a cold pack, this is myasthenia gravis. Now would not take too much of time. I would be just telling you what are the various other causes of acquired ptosis. So you have myasthenia gravis, you have a third nerve palsy. We would discuss this when we would discuss the neuro-ophthalmology, and then we can have conditions like traumatic ptosis. There is a trauma to the eye, or sometimes even tumors can cause it. The basic treatment of this ptosis is the surgical treatment. Before surgical treatment, we see that the patient is not having a complicated ptosis. So before I go and discuss the surgery, I tell you what is the meaning of complicated ptosis. The complicated ptosis means, let's say the patient opens the mouth. So when he opens the mouth, his ptosis decreases, his eyelid opens, but when he closes, there is again a ptosis. So variation of amount of ptosis with jaw opening. Can anyone tell me what is the reason? This is a very important phenomena which is called Marcus gun jaw winking phenomena. Have you ever heard the name? So this is a abnormal communication between the third nerve and fifth nerve. There is a miscommunication or abnormal innervation of the third and fifth nerve, which causes the eyelid to open when the mouth is basically open. Okay, so they would basically show you a picture where when the jaws are open, or he basically moves the jaws right or left, the eyelid movement is according to that. This is called a complicated ptosis. Now we come to the surgical management of ptosis. Now, before I tell the surgical management of the ptosis, tell me what is the muscle which basically opens the eyelid? Can you answer it in the comment section? Which muscle basically opens the eyelid? Anyone? So this is the muscle in the eyelid, which is levator palpebrae superioris. So when our eyelid is basically not working, this means that I have to make the LPS more strong. So any surgery which makes the muscle strong, that is called resection. So I do LPS resection in the cases of ptosis to make it strong. But sometimes even LPS resection cannot be done, and I do not want to cut my muscle. So I can do other surgeries, which is called Fencinella Stewart surgery, which is a milder surgery. Do not go into the details what are done in the surgery, but Fencinella Stewart can be done in mild case of ptosis. Let's say in the cases like Horner syndrome, where there is a mild amount of ptosis. Now the third condition is, let's say that LPS is not working. So even if you do resection, you make the remaining muscle strong, still it is not working. Then what would you do? You would put an artificial sling, okay, inside the eyelid to basically open it. This is called sling surgery. So sling surgery is done when the LPS is not working, or even when you have done the LPS resection, still there is a ptosis. Okay, so with this I end with the ptosis part. Now we come to the last topic of the oculoplasty, that is the eyelid tumors. So there are a lot of benign tumors, malignant tumors, but the benign tumors, the important ones, do not have to go into too much of detail, is that you should be knowing there is a tumor in the children where you see reddish part in the eyeball, sorry, in the eyelid, that is called capillary hemangioma, which after dermoid is the most common benign tumor in childhood, and usually it is self-resolving, or you can give a oral propranolol. The one which is more important is the tumors which are malignant tumors. There are three main types of malignant tumors. The first one is basal cell carcinoma. So basal cell carcinoma is the most common tumor of the eyelid. It is the most common tumor of the eyelid. And remember, the first thing that it does is it basically involves the lower eyelid. Okay, so it involves the lower eyelid first. They would ask that there is a rodent shaped cancer in the lower eyelid. What is the most probable diagnosis? The most probable diagnosis would be basal cell carcinoma. So lower eyelid is the most common location of the basal cell carcinoma. And usually what it does is it basically eats the tissue of the lower eyelid. We call it nodulo-ulcerative lesions. Slowly and slowly it can involve the other parts of the eyelid and it can go intraocularly as well. But the problem here is that these tumors of the basal cell carcinoma, they are not very responsive to the chemotherapy. You have to basically surgically excise the tumor. So surgical excision is the treatment of choice. And after you surgically excise it, you excise the lesion, you send it to the biopsy, and then it confirms the diagnosis. So this is a question which is asked again and again in pathology also. Your pathology teacher would also tell that if your histopathology is showing in the dermis basaloid cells, this confirms the diagnosis of basal cell carcinoma. Okay, so second tumor which is a less common, is a squamous cell carcinoma. Okay, now the squamous cell carcinoma, these patients usually have some pre-existing cancerous lesions. So these pre-existing cancerous lesions can be like actinitic keratosis, sometimes a disease which is called Bowen's disease, or there can be history of radiation. These patients are already predisposed to squamous cell carcinoma. If they give you a question where they say the patient has come with the ulcerative growth in the lower lid, what can be the probable lesion? The first choice is basal cell carcinoma. But if they say that the patient already have a squamous cell carcinoma elsewhere in the body, or the patient is having a actinitic keratosis or a radiation dermatosis or Bowen's disease, then these patients are having more chances of getting squamous cell carcinoma. I told you that the basal cell carcinoma is also called a rodent ulcer. But remember, in squamous cell carcinoma, though there can be ulcerative lesions, most of the times they have elevating fungal lesions, fungating. So you are having not fungus here, so you are having a lot of big lesions going here and there. Okay, maybe involving even the conjunctiva, which is causing a ocular surface squamous neoplasia as well. So the lesions are bigger in these cases and more towards the eyeball and more basically spreading here and there. So that is more going towards the squamous cell carcinoma. Now, as soon as you basically see a squamous cell carcinoma, one thing you always do is you palpate this area. Now, can you tell me why in a squamous cell carcinoma of eyelid you palpate this area? Because you have submandibular nodes where this can metastasize. So squamous cell carcinoma is very much notorious for its metastasis to the submandibular lymph nodes, and here also do the excision, and after the excision, for confirmation of your diagnosis, you do the histopathology and you see the specific type of pearls in this area. Can anyone tell what is the characteristic pathological feature of the squamous cell carcinoma? It is keratin pearls. Okay, so now I come to the most important type of lid carcinoma, that is the sebaceous cell carcinoma. Now why I tell that this is the most important type? The reason is it is the one which is seen in older age group. It is more common in India and it is seen in the upper eyelid. Okay, so this is the sebaceous cell carcinoma, and I would just show you a picture of one of the patient we got few months back of sebaceous cell carcinoma. Can you see here? Everyone give me a thumbs up. So this is a sebaceous cell carcinoma. How would you get that? The patient is an older individual. Okay, there is a lid mass here. This lid mass is more having yellowish type of lesions. It has destroyed the lid architecture. So all these points are basically giving a hint of that this may not be a basal cell carcinoma. This is more likely a sebaceous cell carcinoma. So it is more common in Indian subcontinent. I told you patients with recurrent lesion would be having this sebaceous cell carcinoma more. It is more common malignancy in the upper lid. Okay, arises from the meibomian glands, and very important is it causes distortion of the lid architecture. Now see the normal lid, see this lid. So this causes the distortion of lid architecture. When you do a histopathology, you get a pegytoid spread. Now what is the meaning of pegytoid spread here? Now this is your lid. Here there is main lesion of sebaceous cell carcinoma. Sebaceous cell carcinoma is here, and after some time you see a lesion here as well, here as well, here as well, and the space between them is normal. Okay, so this is called a pegytoid spread. So if I want to summarize the histopathological characteristics, if I want to summarize the histopathological characteristics of all the three types of tumors, tell me what you see in the basal cell carcinoma. This is more in the lower lid, and what you see is the basaloid cells. Is it clear? Give me a thumbs up. When you do it for squamous cell carcinoma, you see the keratin pearls. Okay, and last but not the least, when you do it for sebaceous cell carcinoma, what you see it? You see it with pegytoid spread. Is it clear, everyone? Okay, so with this I basically end the oculoplasty part. We have talked about lesions, important lesions in the orbit. We have talked about the important lesions in your eyelid. We have talked about the important lesions in your lacrimal apparatus. So now after this we would have a 10-minute break. Before going for break, I just want a small revision of the most irritating part of ophthalmology, and even I would say whole of the medical preparation, that is the most common. Okay, so we have done everything. We are just revising. Those students who want to basically take a break early, you can do it. I'm just doing a revision of the most common in ophthalmology. Okay, so give me a thumbs up who are here, who want to have this 5-minute revision. So tell me, what is the most common intraocular tumor of children? Intraocular tumor of children. Write it in the comment section. So you are right, we have retinoblastoma. If we talk about most common intraocular tumor of adult, who are here? Then the answer here is metastasis. Okay. Now I would not write most common. If I ask most common malignant tumor of orbit, remember malignant tumor of orbit in children, what would it be? It would be, remember, rhabdomyosarcoma. Now, if we talk about most common malignant tumor of eyelid. So if we talk about most common malignant tumor of eyelid, then the answer would be basal cell carcinoma. If I ask most common primary intraocular tumor of adult, then it would be uveal melanoma. If I ask most common malignant tumor of lacrimal gland, then it would be, I told you, adenoid cystic. Okay, so my friends, those I think I have given the link of the FMG notes, rapid revision FMG notes, to everyone. If anyone wants to get it, you can basically take it. It's in the ebook format, and there the images are also there. If you want to join our WhatsApp or Telegram group of basically only ophthalmology, you can basically join that too. It would be complimentary for all of you till your FMG exams. So you can see there any more topic you want, you can basically contact to us also. Okay, so now we would be taking a 10-minute break, and then we would be 15-minute break, sorry. Then we would be coming with a very important topic, and sometimes it is more difficult, that is the squint. And then if the time permits, we would basically start with the neuro-ophthalmology as well. Okay, let's take a come back after 15 minutes. Thank you.
चेक कर लीजिए, अगर पेन से चल रहा तो ठीक है, मतलब चाहे लगा दो।
नहीं, इसके साथ नहीं चलता यार वो।
फिर तो बंद।
सही काम चल रहा है अब, 2 घंटे का रह गया। खत्म कर दें इसको, कार्यक्रम को आज चेक करना वॉइस।
वॉइस तो ठीक है सर।
उप्स, 1 मिनट। हाँ ये कर दो एक बार, वो तो किया नहीं मैंने।
नहीं वो नहीं।
So now friends, we would start with the squint and neuroophthalmology. Though I feel that they are not as difficult chapters, but for this I would require your more support, because if you find any topic difficult or anything which you are not able to understand, remember, as a teacher it takes me around 12 to 13 years. I am doing the I am guiding and mentoring the students of AIMS and the other institutes for last 12 years, and I am able to basically have a concept and have a grasp over this subject after so many years, and every day we learn. So even if you are not able to learn something, if you are not able to understand something, it's absolutely fine. Okay, so you would learn with time. And how would you learn? You would learn with more and more MCQ practice. So I would request that all of you please join our Telegram group as well for MCQ practice. We would be giving the notes and we would try to make some concepts easier by this lecture. So give me a thumbs up if you are 100% attentive, and just rub your hands, okay, like this, and have your full concentration over this lecture for next 1 hour. And then we would talk about, initially we would talk about squint, then we would talk about the neuroophthalmology. Is it clear? Give me a thumbs up, everyone. I want all the 60 of you should be giving the thumbs up. Okay, so before we start with the squint section, I would be talking about the important points regarding the various cranial nerves, which are basically having a innervation of the eye, and which are used, which whose concepts would be dealt in this squint and neuroophthalmology. So the nerves which are most important is the optic nerve, the cranial nerve 2, the cranial nerve 3, the cranial nerve 4, and cranial nerve 6. because 3, 4 and 6 they innervate our extraocular muscles, and optic nerve is very important for your visual field pathway defects as well as for your optic neuritis and your papilledema. Okay, so first of all, the optic nerve, that is the cranial nerve 2, its length is around 45 to 50 millimeter. The smallest part is inside the eye, that is the intraocular part, which is 1 millimeter, and then we have intraorbital part, which is the having the maximum length, that is around 30 to 35, 25 to 30 millimeter. Then we have intracanalicular part, which is around 5 to 9 millimeter, and then we have the intracranial part, which is around 10 to 15 millimeter. So the question that comes from this is, we would be going very slow, don't worry, that which is the largest part of the optic nerve. So intraorbital is the largest part of the optic nerve. This was a previous year question. Okay, now there is a controversy regarding the first order, second order and third order neuron. I think this is a more of a section which the anatomists would do, but whatever I have learned in my aims is the concept of bolo. So then this mnemonic, B goes with the bipolar cells, which is my first order neuron. O goes with the optic nerve. This is my second order neuron. And low goes with the neurons from LGP2, occipital lobe, which is third order neuron. There is a slight amount of controversy regarding which is the second, which is the third, but I go with this one. Hope this mnemonic would be useful for you. Okay, now we come to the oculomotor nerve. This is the third nerve. Now this third nerve, why this is important? Because most of our extraocular muscles, we have 4 extraocular muscles which are being supplied by the oculomotor nerve, which are superior rectus, inferior rectus, medial rectus and inferior oblique. Okay, so they are being supplied by the third nerve, which is the oculomotor nerve. There was one question in anatomy that the nucleus of the third nerve is present where? Can anyone tell me? So the nucleus of the third nerve is present at the level of midbrain, at level of superior colliculus. Okay, this was also a previous year question, so please remember. Okay, from third nerve we go to the fourth nerve. Now why this fourth nerve is important? Because it supplies the contralateral. Okay, so the right side supplies the left superior oblique, the left nucleus supplies the right superior oblique. Okay, so it supplies the contralateral superior oblique. And second thing, why I would be basically giving you more emphasis towards the trochlear is that it has the longest intracranial course. It has the longest intracranial course. So because it has the longest intracranial course, it is more subjected towards the damage if there is a head trauma. Okay, so if there is a trauma to the brain or trauma to the head, the chances of trochlear nerve getting damaged is more. Okay, so now we come to the sixth nerve, which is abducens nerve. Now, like your trochlear nerve, which basically supplies the contralateral part, the contralateral extraocular muscle, the abducens nucleus basically supply the ipsilateral one. Okay, so it supplies the ipsilateral lateral rectus. So remember LR6 SO4. So lateral rectus supplied by 6th nerve, superior oblique supplied by 4th nerve, and the lateral rectus supplies the ipsilateral. So the 6th nerve supplies the ipsilateral lateral rectus. Now here also remember that the nucleus of the abducens is at what level? It is at the level of pons. And I forgot to tell you, the nucleus of trochlear is at the level of inferior colliculus. Okay, we are going very slowly but firmly. If you have any doubt, let me know. So I repeat it, that nucleus of the third nerve is at superior colliculus, already a question. The nucleus of trochlear is at the level of inferior colliculus, also a previous year question. And nucleus of the abducens at the level of pons. Okay, and lateral rectus supplied by 6th nerve, superior oblique supplied by 4th nerve, rest all the nerves are supplied by the rest all the muscles are supplied by the third cranial nerve. Is it clear, everyone? Just give me a thumbs up. Okay, now with this we come to the extraocular muscles. So these are our extraocular muscles. Some faculty tells 6, some tell 6 plus 1. I would also go with the 6 ones. So the 6 extraocular muscles are 4 rectus muscles. Tell me the name of the rectus muscles. The superior, the inferior, the medial, and the lateral. And we have 2 obliques, the superior and the inferior. Okay, so these are our muscles. Let's see where the muscles start from. Can you see this diagram? So most of these muscles you can see are from this region. Okay, so what is this region called? This region is called annulus of Zinn. Okay, so all the muscles except this one, okay, they are coming from the annulus of Zinn. But I want to make your attention please towards this yellowish muscle. This yellowish muscle, though is starting from this area, is taking a turn from a bony outgrowth, and then it is basically being attached posterior to the central part of the eyeball. This line I call it equator. If you are able to understand this point, give me a thumbs up. So we have all the muscles except these two starting from the annulus of Zinn, and one yellow muscle is basically taking a turn from a pulley and getting attached to posterior to the equator. Now what are these muscles? So this muscle, which is basically supplying the upper lid, is, anyone, what is the name of this muscle? It opens the eyelid. Another hint I am giving, it is also supplied by the third nerve. So very good, this is the levator palpebraris superioris. Then we have these other muscles. This muscle which is taking a turn, which is going superior, taking a turn and basically attaching posterior to the equator. My name is superior oblique. Okay, and then we have this muscle which is basically starting from the inferior part of the orbit. Are you able to get my point? Inferior or part of the orbit, which is the maxilla, maxillary bone. This is basically the inferior oblique. Is it clear, everyone? Okay, so this is the important muscles, the 6 muscles plus the one that is LPS. Now one more question they ask sometime, which is the largest muscle, or which is the muscle which has the longest course, and which is the one having the smallest course. From this diagram, now it is very clear that this muscle, yellow muscle, goes up, goes down, and then is basically there. So my superior oblique is my longest muscle, and the one which is inferior oblique, a very small one, starting from here, attached here, this is my shortest or smallest muscle. Give me a thumbs up if you are able to get these points. Is it clear? So this is all about you should know regarding the muscle anatomy. Now we come to the movements of the eyeball. Now please see me. Now I close my one eye. I look right, up, down, left. So if basically I am doing the movement, I am seeing the movement of my one eye. This is called duction movement. So what is duction? Duction is a uniocular movement of a one eye at a time. Is it clear, Dr. Ajit, Dr. Digvijay? Now you say, sir, normally this does not happen. You have both the eyes. So see from both the eyes. I look up, I look towards right side, I look towards left side, down this side, left side, up right side, up left side. Okay, so when I am doing the movements from my both the eyes, this is my version movements. Okay, so they are the binocular movements. Binocular movements moving both eyes on a focus. Give me a thumbs up if you are able to understand this. Okay, so similarly we can have the various movements with us. We can have the movement of eye straight. When I tell the movement of eye straight, can I call it primary? Okay, when I look left, can I call it levo version? If I look towards the right, can I call it dextro version? I am writing dextro plus V. When I am looking down, can I call it depression? When I am looking up, can I call it elevation? When I am looking levo and up, left and up, can I call it levo elevation? When I am looking left and down, can I call it levo depression? When I am seeing right and up, can I call it dextro elevation? Can I say it dextro depression when I am seeing down and in the right? Now, if it is clear, write OK in the comment section. So we have 9 gazes through which we have to test our movement of the eyeball. Now comes what is the definition of squint. So squint is basically misalignment of visual axis. Okay, so normally when I see with the both the eyes, I should basically both the eyes have the same angle at which we should basically look at the object. So this means, let's say I have this object here, from both the eyes I should look straight and this angle should be here. Okay, when this pattern is basically lost. Now why would this pattern would be lost? When there would be a problem in the coordination between all the extraocular muscles, or there is a problem in the strength or movement of any extraocular muscle, we would get a squint or strabismus. Okay, so that's why I took your 5 minutes in basically telling you what are the various extraocular muscles, and now we would be talking about what are the actions of various extraocular muscles. Okay, so before I tell you the action of the extraocular muscles, now these are my two eyes. Okay, this is my nose. I do not want you to give too many mnemonics, just understand. Squint is all about understanding. Now here, just remember this diagram. Okay, this is a diagram I want you to remember to know about the action of my rectus muscles. Okay, and oblique muscles. Then I have that green arrows. These green arrows, this one is my lateral rectus, this one is my medial rectus. So one that is towards the nose, you make it superior rectus. This is inferior rectus. Now obliques. Oblique means that there is not straight, it is turned. So superior oblique put down and inferior oblique put up. Now this diagram I have made only to understand the actions of muscle. It does not have to do anything regarding where the muscle is attached. Now is this diagram visible to you? Because this would basically solve at least 2 questions in your PG exams. Very high yielding. Now first think about superior rectus. I have made the diagram like this. Is it clear? Okay. Now, when we talk about up, that is called elevation. Okay. When we talk about moving the eye towards nose, that is called adduction. Okay, now this is the topmost and this is the bottom part. I call it 0 or 12 o'clock position, and this is 6 o'clock position. Okay, like a watch. You have a watch now. You have a watch like this. So you have 12 and 6. This is similarly here. If I make the 12 o'clock position to go towards the nose, okay, this movement, this turning movement of the eyeball, which basically makes 12 to go towards the nose, okay, so this is called a intorsion. Give me a thumbs up if you are able to get my point. Okay, So this is superior rectus. My primary action is elevation. My secondary action is intorsion. My tertiary action is adduction. Is it clear to all of you? Give me a thumbs up. Okay, chalo, let's move to the inferior rectus. In inferior rectus, we make a diagram. So whenever we talk about the superior and inferior rectus, their primary action is either elevation, elevate the eyeball, or depress the eyeball. So what would be my primary action, right? P is equal to, what would be my primary action? It is basically moving the eye down. So can I write primary action is depression, then my secondary action is this one, turning the eye. Now here what is happening is, if it is turning like this, see, if this eye is basically turning the eye like this, so it would basically keep the 12 o'clock area away from the nose. Okay, so it would move the 12 o'clock away from the nose. Are you getting my point? So 12 o'clock is going away from the nose. If it is moving the eye like this is called extorsion. So my secondary action is extortion. If anyone not able to get this point, let me know again. But remember, the primary action of superior rectus is intorsion. Basically, it is moving the 12 o'clock position towards the nose. And the secondary action of the inferior rectus is the extorsion. Is it clear, Dr. Gunjan, Dr. Jeet? So secondary action is extortion. Now comes the tertiary action. Tertiary action is, again it is moving towards the nose. Okay, so the tertiary action is again adduction. Okay, so my superior rectus and inferior rectus, one action that is common in both of them is adduction. Okay, so they would ask which action is common in both superior and inferior rectus. You would answer it as an adduction. Is it clear, everyone? And superior rectus is intorter and inferior rectus is extorter. Okay, chalo, let's move to the medial rectus. Now medial rectus is very easy. Medial rectus has only one action. It moves the eye towards the nose. So it is adduction. And the lateral rectus has only one action. It moves the eye away from the nose. This is called abduction. I'm not getting any response from you. I want everyone to basically move your thumbs, move your fingers and understand the concept. Now comes the difficult concept. Remember, superior oblique, you should be remembering the diagram. Superior oblique is towards the inferior part in the lateral side, and inferior oblique is towards the superior part in the lateral side. So can I make a diagram here? For my superior oblique. Okay, so this is my superior oblique. Now the first action of superior oblique is this one. It moves the eye like this. This is my 12 o'clock position. This is my nose. So tell me, what is this action, primary action? Moving the 12 o'clock towards the nose. What would be my primary action of superior oblique? So my primary action of superior oblique, it would be moving the eye towards 12 o'clock position towards the nose. It would be intorsion. Is it clear, everyone? This one. Secondary action is it moves the eye down. So what is my secondary action? Secondary action is depression, and it moves the eye away. What is this action? This action is abduction. Okay. So we have superior oblique as intorter, depressor and abductor. Do you all agree? Okay. Now see superior oblique, intorsion, depression and abduction, and see superior rectus, elevation, intorsion and adduction. Now my question to you is, which action is common between the superior rectus and superior oblique? My question is, what is common between the superior rectus and superior oblique? So both are intorters. Move the eye, topmost part of the eye towards the nose. Is it clear? Okay. So can I write it? Sin. Remember it with the mnemonic sin. So superiors are intorters. Okay. Now my last muscle. Hope I am not too much fast. If you have any doubt, let me know. So this is my globe. Okay. And here we have the extraocular muscles. Okay. So these extraocular muscles is my inferior oblique. Is it the shortest muscle of the eyeball? Yes. So this inferior oblique, basically the first thing it does is it rotates the eyeball. This is my 12 o'clock position. It basically rotates the eyeball 12 o'clock away from the nose. So what I call this action, when it is basically taking the eye away from the nose. So can I say this is extorsion? Okay, it is coming away from the nose. Then my secondary action, moving the eye up. So can I call it elevation? Okay. Now my tertiary action, it is basically moving the eye towards the ear. So this is my tertiary action. This is abduction. Give me a thumbs up if you are able to understand this point. Okay. So my inferior oblique is extorter, elevator, and my inferior oblique is abductor. Is it clear? Now my one more question to you is, which action is common between inferior oblique and superior oblique? Both does the same action. Okay, so we know that this also does abduction and this also does the abduction. Okay, so can I say here both superior and inferior obliques, they are the abductors? Give me a thumbs up if you are able to understand this point. Okay, chalo. Let's move to the next topic, that is the how these muscles coordinate with each other. So for knowing the coordination, we should first be knowing what is the meaning of yoke muscles. Now there are two very good friends, best friends. they always move together. So yoke muscles are also like this. They are synergistic muscles. They always move together. What they mean, that whenever you do a version movement, version means whenever you do a binocular movement, they do the same movement. Okay. So let's say I am basically moving eye here. Okay. My moving eye here. This is my dextroversion. So both my right eye and left eye are seeing this. When I am moving up, both are moving up. Okay. So yoke muscles are the best friend muscles. They are synergistic muscles. They do the same version movement. Is it clear till now? Okay, it would be more clear now. Now this is my eye, and this is a stick which is there in my right side. So to this stick, to see this stick, my right eye moves here and my left eye moves here. Do give me a thumbs up if you understand this. Okay, so this is my dextroversion. Okay, so to do this, we have right and left both moving in the same direction. This is, so now what are the muscles that are involved? So my right side is moving towards the ear. Tell me, which muscle is involved in the right side? Which muscle would be involved in the right side? So it would be right lateral rectus. Okay, and which muscle of the left eye would be involved? Left eye is going towards the nose. So there is a adduction movement of the left eye. So what would be that muscle? So that would be left medial rectus. So can I say that right medial rectus and left medial, sorry, right lateral rectus and left medial rectus, they are the muscles which are friend muscles. These are the yoke muscles. Okay. So now we have this diagram which would basically show you what I have told, that if we talk about the right eye, right medial rectus and left medial rectus, they basically tell the eye towards the dextroversion, and if we go towards the nasal side, right medial rectus and left lateral rectus, they are the yoke muscles. Okay, everyone? Now, the concept is now a bit difficult when we talk about the dextro elevation and the levo elevation. Okay, now there is a stick here and I have to see here. Okay, this is the normal position. To see here, one eye has to go up and out and other eye has to go up and in. Are you getting my point, everyone? So one thing that is common is that this muscle should be a elevator. Is it clear, everyone? So one thing is for sure is this muscle should be either superior rectus or inferior oblique. Is it clear, everyone? So because superior rectus and inferior oblique, only these are the muscles which are the elevators. Okay, now both of them cannot be superior rectus because in one eye there is a up and in motion and in other eye there is a up and out motion. Okay, so superior and inferior oblique, we know superior rectus and inferior oblique, they are the elevators. Okay, so when we talk about the dextroversion, okay, when we talk about the dextroversion, the up and out movement. So when we talk about the out movement, then remember it is the superior rectus that is involved. And when we talk about the in movement, I am talking in conjugation with the your elevation. Okay, when I talk in movement, then it is the inferior oblique. So dextro elevation, the yoke muscles are right superior rectus and left side inferior oblique. Remember, whenever we talk about yoke muscles, one muscle should be of one eye and other muscle should be of the other eye. Okay, so you have to be both the muscles. You cannot have right superior rectus and right inferior oblique that are the yoke muscles. Yoke muscles should be of the both the eyes. Now let's do one more example. We have similarly dextro elevation. Now tell me, what are the yoke muscles here in the dextro elevation? So one muscle is up and in. This is of the right eye. So right eye we have inferior oblique and the left eye up and out. So this would be left superior rectus. Okay, so my right inferior oblique and left superior rectus, they would be yoke muscles for my levo elevation. Similarly, if we move to levo depression, one eye is moving down and out, other eye is moving down and in. Okay, and we know what are the muscles which are causing the depression. We have two muscles, superior oblique and inferior rectus. They are the ones which are the depressors. Okay, so I come back to my diagram again. So we have inferior rectus and superior oblique, which are the depressors. So when we talk about the levo depression, down and out position, so down and out, we have the rectus involved, and when we say down and in, we have the oblique involved. Okay, so my levo depression, my muscles that would be involved are left eye, we have inferior rectus, and right eye superior oblique, that would be our yoke muscles. Just let me know if you are able to understand till now. We would now, how would we would basically, now this is something that you may understand right now, but when you get questions you may get confused. So we would do more and more MCQs regarding these type of questions. Okay, so this is the concept of the yoke muscles. I think that this concept may be 15 to 20% clear to you. So even if you are able, because I mastered, there was no one when I was studying in for my AIMS exam to basically tell me that. So we mastered it after many years. So if you can basically understand 15 or 20% of what I have told, it is more than sufficient. Okay, so slowly and slowly you would master by doing more and more MCQs. Remember, practice make it perfect. Okay, now we have two laws. So now squint is like mathematics and physics. It is basically going towards some laws. So first law is a very simple law. So Herring law is basically says that yoke muscles should get equal innervation. Yoke muscles should get equal innervation. Now what this mean, that if my right eye is moving 2 millimeter laterally, my left eye should also move 2 millimeter medially. Okay, so this is my A, this is my B. So if A is going 2 millimeter, the B should also go 2 millimeter. Okay, this is called Hering's law. Now you would say, sir, this is very obvious. So I also say this is very obvious that the both muscles should be equally. But remember, if this is not the case, if one eye is moving more, because let's say our one hand is working better than the other hand, so even if one eye is moving more than the other eye, then there would be imbalance and there would be squint. Okay, so to maintain the alignment of the eye, both the eyes should be basically moving in the same amount. This is called Hering's law. Okay, now then there is the Sherrington's law. What the Sherrington's law says, that we have eye, we have two muscles. Now there are two muscles. One muscle is medial rectus. This is, let's say, my nose, and one muscle is lateral rectus. So both are antagonist. Like husband and wife, they are antagonist. Okay, so we have the medial rectus and lateral rectus. Medial rectus would go this way, lateral rectus would go this way. Okay, so when one eye is moving, when one muscle is moving, the other muscle should be quiet. Okay, so when one muscle is moving, there is an innervation. Remember why the muscle moves? Because the brains tell them to move. So when the one muscle is moving, other muscle should not move. This is called Sherrington's law. Okay, so Sherrington's law is, when one muscle is moving, its antagonist should not get innervation. Okay, otherwise the movement would not be possible, or because of the movement in the opposite direction, I would go inside. There is a disease when the Sherrington's law is not maintained. One eye is also moving, other muscle is also moving. Because of this movement, the eye goes behind or retracted. Okay, so here, if in a normal condition, they should not basically move together. This is called Sherrington's law of antagonist muscles. Okay, so with this, I basically tell you about, I revise whatever we have taught till now. We have talked about the second nerve, we have talked about the third nerve, we have talked about the fourth nerve, we have talked about the sixth nerve, and then we have talked about the origin of the extraocular muscles, the various extraocular muscles, the action of the extraocular muscles, and we have talked about two laws, that is your Hering's law and the Sherrington's law, and we have talked about what are the yoke muscles. Is it clear till now, everyone? Should I move to the next topic? Because we are going very slow. I have to basically cover the squint and neuroophthalmology part as much as possible today. So then we have light chapters tomorrow. Okay, now we come to the various tests that we should be doing to evaluate the squint. Now at your syllabus, at your level, they are not going to ask you the interpretation of the test, but you should be knowing about the test. The first of all is this test. Now this is called a Maddox rod test. Actually it is not a rod, it is a lens, but you can see striations here. Okay, so this Maddox rod, when we put in front of eye, let's say our eye is moving up or down, one eye is moving up and other eye is moving down, so we have a hypertropia or a hypotropia. So we can have the lens in front of our eye where the striations are either vertically for the hyper or hypotropia, or we can have them horizontally for horizontal squint, like the patient is having ezo or exotropia. Is it clear, everyone? So this is called a Maddox rod test. The other test which we are doing here is a prism bar cover test. Now what is the meaning of prism bar? Can you see this bar prism? So what we are doing is we are covering one eye, putting a prism in front of the eye, see the deviation of the eye, then we cover the other eye and see the deviation of the other eye. So these are the prisms which neutralize the squint. How they neutralize we would study again, but here just remember that this is a test basically which is used to see what is the amount of deviation and where is the deviation, whether it is a esotropia going comes inwards, or exo, or a whether there is a hypo where eye is going down, or a hypertropia. Okay, so this is what is your prism bar cover test. Okay, then we have this instrument which is called a synoptophore. See this instrument. Here you put your eyes here, chin here, and you are shown plates in this area. Various plates are shown and you basically see the plates, and the light, the examiner sees how much is your muscle working. Okay, so in one side we are seeing where is the muscle working, and in the other side we are seeing where is the position of the eyeball. So we can basically see how much is your deviation. This instrument is called synoptophore. Is it clear, everyone? Give me a thumbs up. Okay, last but not the least, see this chart. Here this is my left eye and this is my right eye. If you can see these black arrows, these black arrows are showing us how much is the deviation of the eye and which muscles are working. You can see that here the lateral rectus, the abduction is going on and small amount of deviation is going on. So all the muscles are not working, only lateral rectus and small bit of downward movement is basically working. So this patient may have a third nerve palsy because other muscles are not working. Lateral rectus makes the eye out, superior oblique makes the eye down, only these are working. This chart which shows the action of the muscles, this is called a Hess chart. Is it clear? So this is the Hess chart. Now what is another test which you can do in your OPD? For these things you need instrument. A simple test which I think one of you have asked me when I was talking about the proptosis, that is the test which we can do with the torchlight. So you put the torchlight in front of the eye, okay, and with this torchlight you see the white light, the pupillary reflex that is coming. Okay, so this is my eye. This is my cornea, and in the center of the cornea we see a reflex when we show a light. Is it clear, everyone? So this angle should be equal in both the eyes. Now let's say in this patient this goes here. Okay, so the pupillary reflex you are seeing over the edge of the pupil, not in the center of the pupil. This means that the eye is going outwards. Are you getting my point? I make it again. So let's say this is my eye, this is my center of pupil. Now eye goes away. So when the eye goes away, this light instead of center is basically at the pupillary margins. Okay, so now this angle is less as compared to this angle. So this patient is having a eye moving on the side of ear. This is called exotropia. Give me a thumbs up if you are able to understand. And this test, even if you do not know the interpretation, it's absolutely fine. This test is called Hirschberg test. This test is called a Hirschberg test, and through this Hirschberg test, we can also tell in our OPD whether the patient has squint and what is the type of squint in the patient. Okay, so with this, I start with the clinical squint. We have 4 types of major squint. The eye may be going up. Okay, when the eye is going up, I call it hypertropia. The eye may be going down. I call it hypotropia. The eye may be going laterally. I call it exotropia. Eye may be going towards the nose. We call it esotropia. So these are the 4 major types of squint. Okay. So we would study about these types of squint in our further discussion. So first of all, before we talk about the various types of squint, sometimes there are latent squint. In few of the times, let's say when I am very much tired, then I think that the patient, my relative says that Vineet, your eyes are moving out, but normal condition my eyes are okay. So this squint which is there, sometimes because of some my weakness or too much of tiredness, but not all the time, that is basically called phorias. So phorias are our latent squint, and tropias are our when the squint is present in all the time, we call it manifest squint. Okay, the latent and the manifest squint. Okay, so now sometimes what happens is we talk about a small child. There is a 1-month-old child who your parents bring it to you, and you see both the eyes are coming in a iso direction. Okay, both the eyes balls are towards your nose. Okay, so this is a infantile esotropia. Now first question the examiner would ask you, whenever you get a esotropia, which muscle is working more? Is it a medial rectus or lateral rectus? So overaction of which muscle and underaction of which muscle? So can anyone tell? OA, write it, and UA. So I am talking about esotropia. Eye is coming towards the nose. So my both the eyes are adducted. Okay, so we have a overaction. Very good, Dr. Manoj. The overaction would be of my medial rectus, and there would be a underaction of my, what is the antagonist of the medial rectus? That is your lateral rectus. Either my lateral rectus is working less or my medial rectus is working more. Okay, so similarly, very good. If we have a patient of exotropia, okay, if we have a patient of exotropia, which muscle is working more and which muscle is working less? So we have a overaction of and underaction of which muscle? So my lateral rectus is working more, overaction of my lateral rectus and my underaction of medial rectus when we talk about the exotropia. Is it clear, everyone? Okay. Now similarly we can have various types and combinations of squint. The important thing that you have to remember is how to basically treat the squint. First of all, when you go for treatment, do a conservative treatment. This squint can be because of the uncorrected refractive error. So first thing you do in these patients is, for treatment, you have to basically correct the refractive error. Because of too much of accommodation, the patient may be having the overactivity of your medial rectus. So correct the refractive error. Here comes a previous year question that usually we would study it in our optics part. Whenever the patient is having hypermetropia, he is more predisposed, not all the times, more predisposed to get esotropia. When the patient is having a myopic refractive error, myopia, he is more predisposed to get exotropia. Please remember this, cram this point. Okay. Now the next thing is that even after refractive error, if this is not corrected, then what to do? In that case, even if this is not corrected, the next thing that we do in these patients is we can do surgical treatment. So for surgical treatment, when I talked about the surgery of the LPS, levator palpebrae superioris, in ptosis, I told you whenever we have to basically make the muscle to act more, we have to do the resection. So we have a strengthening of a muscle. If I have to do in strengthening, we would basically do a resection. If we have to do weakening, we would do the recession. Okay, so strengthening is resection and weakening is recession. Now we come to back to what we have studied. Let's say we have a exotropia. We have a exotropia. Give me a thumbs up if you are able to understand. If I am going fast, just let me know. If we have a exotropia, we have a overaction of lateral rectus and underaction of medial rectus. So what surgery I would plan in this patient to correct it? So I would basically try to weaken the lateral rectus. Lateral rectus को मुझे और weak करना है, और I have to basically make medial rectus more strong. Okay, to correct exotropia, I have to basically do the weakening of lateral rectus and strengthening of the medial rectus. Is it clear, everyone? Okay, so for levator rectus weakening, I would do the recession, and for medial rectus strengthening, I would do the medial rectus resection. Give me a thumbs up if you are able to get the point. Okay, so now one question for you. Let's see if I have that question. Okay, so first of all, tell me which is the wrong pair of yoke muscles. So a small revision before I end the session of squint. What is the wrong pair of yoke muscles? Right superior rectus, left inferior oblique, right superior oblique, left inferior rectus, right medial rectus, left medial rectus, or right inferior rectus, left superior oblique. So very good, Jashna. Remember, if one eye medial rectus is there, the other eye should be lateral rectus. Okay, so the answer here would be C. Okay. Chalo, what is the test being done here? Is it a Hess chart, cover test, prism bar cover test, or synaptophore? So very good. This is a prism bar cover test going on. Okay. So let's have one more question. Mark the wrong statement. Inferior oblique, superior oblique, medial rectus, adduction and intorsion, superior rectus, elevation, intorsion and adduction. Okay, I think all the answers are C only. So medial rectus only does the adduction, it does not does the intorsion. Okay, so with this I end the session of squint. Hope you must be able to understand most of the concepts. So after this we would be taking a 10-15 minute break. We would be back with the last session of the day, that would be on the neuro-ophthalmology visual field pathway defects. We would basically study there, and then tomorrow we would be studying about the optics. We would be studying about the community ophthalmology, systemic ophthalmology, lot of image based questions, and any other topic that you want me to discuss. Okay, so let's take a 15-minute break and then we would be back.